So we'll move on to the next session, which is an interesting case-based panel discussion, which will be moderated by Dr. Mrudul Dharod, who is a consultant in the Department of Hepatology at Reliance Foundation Hospital. The panel I also welcome the panelists for the discussion, Dr. Nipun Verma, Dr. Sunil Dadich, Dr. Ajay Jain, Dr. Nori Fumi Kawada, and Dr. Rushi Deshpande.
Good evening, everyone. I welcome all the panelists. I'm Dr. Mrudul. I will be presenting a case on refractory ascites with AKI-HRS on proteinuric CKD. This is the epilogue. So a 37-year-old male with a history of significant alcohol intake for more than 10 years and no known comorbidities, diagnosed as alcohol-related cirrhosis in 2021 when the index presentation was hematemesis. Subsequently, in March 2022, he had an episode of severe diarrhea where he developed AKI. Creatinine went up to 5 milligrams per deciliter, underwent a cycle of hemodialysis. We do not have further details of that admission. USG abdomen then showed normal sized kidneys. For a while, creatinine did not return to baseline, hovered between 1.8 to 2 milligrams per deciliter. Subsequently, creatinine came down to 1.3, 1.4. He had further decompensations in form of recurrent ascites and an episode of encephalopathy. Admitted in December 2022 with gross ascites. This was in a different city, where this time he was found to have again a creatinine of 2, and they did a 24-hour proteinuria, which was found to be 7 grams over 24 hours. There was no overt history of hematuria. He was transferred and then came to us in Jan 2023 with gross ascites, stable vitals at that time, BP always in the range of 120/70, no hypotension. These were the labs at presentation. So anemia, hemoglobin of 6.9, WBC of 3590. Creatinine at our place was 1.83 milligrams per deciliter. He had a low bicarbonate. UPCR was 6.91 milligram per milligram of creatinine. Spot sodium urine was 44. LFT was otherwise stable, maintained liver function. X-ray did show some congestion, and an endoscopy showed GAVE, for which an APC was done. So first question to Dr. Ajay Jain. So what do you think we are dealing with here, where we have a male with some history of creatinine being on a higher range, came down to normal, and now again has creatinine of 1.8?
Thank you, Mrudul. So if you can go back to the investigation slide, there are a couple of things which we need to look at the investigation. So this patient has a diagnosed cirrhosis. Patient has already decompensated, had a variceal bleed, had an episode of AKI because of diarrhea, and which has hit the kidneys, which recovered not completely. And now when he has presented, his creatinine is 1.83. His UPCR is very high, which is 6.91 milligram by milligram per creatinine. His spot sodium is high, and his urine shows hematuria. So to my mind, this patient has a chronic liver disease, cirrhosis, decompensated, portal hypertension, and now he also has an underlying chronic kidney disease in the form that creatinine is high. UPCR, which is a surrogate marker, again shows that the patient has a chronic kidney disease. His spot sodium is high, which again favors a diagnosis. These are all surrogate marker. And in fact, his urine shows hematuria, which is again a marker that this patient probably has an underlying nephropathy.
Thank you, sir. The patient who has a CKD and now develops an AKI, so we know HRS is one form of AKI. So do you think, sir, can HRS physiology coexist with an underlying chronic kidney disease?
Let me explain that HRS is a phenotypic expression of an AKI. AKI can have different. HRS is a diagnosis of exclusion. Yes. So when you have ruled out other causes of AKI, patient has cirrhosis, patient has ascites, and patient has other features suggestive of decompensated chronic liver disease with all possible causes of AKI ruled out, then you label HRS. So yes, a patient having a cirrhosis decompensated with an associated chronic kidney disease can have HRS AKI, which can further compromise his renal function and further deteriorates his general condition.
Thank you, sir. So, Dr. Dadish, sir, how will you manage this patient?
So, first of all, I think whenever we get a person who is admitted to the ward with cirrhosis, ascites, and AKI, you need to differentiate whether it is a HRS AKI or a primary acute on CKD. So, we need to confirm the diagnosis of HRS first. So, avoid those drugs, not all nephrotoxic drugs, stop diuretics, beta blockers, and assess the volume status of the person. Yes. Is hypovolemic because most of these people are hypovolemic. Give crystalloids to maintain the volume, achieve the euvolemia. And once the euvolemia is achieved, your drugs are stopped, hemodynamically stable, and HRS physiology is confirmed, then you start the combination of albumin and terlipressin. And terlipressin in the dose of 2 milligram, preferably continuous infusion, and be increased every second day if there is no fall in serum creatinine value. And albumin is given around 20 to 40 grams of albumin daily. And then assess on daily basis and stop the drug if there is normalization of creatinine, if there is no improvement with the maximum possible dose, which is 12 milligram. If the person requires RRT for some or other region, then you need to stop those drugs. Or if they develop adverse reaction to terlipressin, like ischemic and respiratory complications. If there is a non-response to albumin terli, then the RRT, renal replacement therapy, is the option for them.
Yes, thank you, sir. So, would there be any difference in the management of any AKI and CKD or an HRS AKI?
Yes,
suppose this patient did not have a CKD, but only pure HRS.
It is important to differentiate between AKI on CKD and the HRS because the pathophysiology is entirely different. In HRS, you have splenic vasodilatation and the renal vasoconstriction, and the renal autoregulation is shifted extreme to the right. So you need some drug which can cause splenic vasoconstriction and renal vasodilatation to improve the renal functions. Requirement of RRT in HRS AKI is less compared to those who have AKI on CKD. And they don't respond to, the AKI and CKD don't respond to the combination of albumin and terli. So the treatment is different. The requirement of RRT is more in this category compared to the HRS category. So it is very important to differentiate between these two conditions whenever a person comes to you.
Yes, sir. So we are commonly seeing these kind of patients in our practice now. Patients with creatinine 1.3, 1.4, and then they come with a rise in the creatinine. Well, previously always used to consider the creatinine should be as normal as possible, 0.8, 0.9. But even 1.2, 1.3 can be considered as CKD, especially in elderly patients. Question to Dr. Nipun Verma, sir. What is the end point of therapy with vasoconstrictors in the treatment of HRS AKI on CKD?
Well, I would like to take this case a little bit differently because so we understand that this patient has decompensated cirrhosis, alcohol related, and there is an evidence of CKD in terms of significant proteinuria, 7 grams, and hematuria, very high UPCR. On top of it, there is a baseline creatinine. So whenever a patient comes to the hospital, we assess its baseline serum creatinine. This patient's baseline serum creatinine within last 3 months was about 1.5.
Yeah.
Now he has come with 0.3 milligram rise.
Yes, sir.
I would label this patient as underlying CKD and top of it there is AKI. Now, whether this AKI is volume responsive or vasoconstrictor responsive is the next step to be seen. Now, according to ADQI definitions and ICA Club joint consensus published 2023, they are defining that HRS can be an inclusive diagnosis rather than an diagnosis of exclusion. So what they say is patient with cirrhosis and ascites who's fitting the criteria of AKI, which this patient is, and on top of it, there is absence of strong evidence of chronic kidney disease. But they also say that a patient can have underlying chronic kidney disease and they can also have HRS. So how do we diagnose HRS on top of CKD? Like in this patient, there is a refractory ascites, there is a typical setting of HRS. And now if we see the volume status is replete, and we see volume status with the help of multitude of modalities like lung ultrasound, like IVC, and simple leg raising test and pulse pressures. So we see that the patient is volume replete, and then we start vasoconstrictor if the MAP is below 80 or 70, and patient starts showing response. That is the kind of phenotype of HRS on CKD. Now, so different types of vasoconstrictors have been described. Terlipressin is usually the initial drug of choice. We give it in infusion doses, 2 milligram to start with over 24 hours. Now they say you need not to wait for albumin to be given for 48 hours and then start terlipressin. They say you assess the volume status at the outset. You can start straight away on vasoconstrictors. So the phenotype is HRS AKI. Now you titrate the vasopressors depending upon the type of vasopressor. Now, like say in terlipressin, you titrate at 24 hours if there is less than 25% decrease in the serum creatinine. So once there is above 25% decrease, you continue the same dose. If there is less than 25% decrease, you increase the dose by 2 milligram or 1 milligram depending upon the tolerability. What is the endpoint? Endpoint is either the complete resolution, which is defined by within 0.3 milligram per deciliter of serum creatinine if it comes to the baseline. That is, the baseline creatinine was 1.5 and the serum creatinine comes less than 1.8. Then you actually stop vasoconstrictor therapy. This is for terlipressin. And you also look for other ancillary findings, including urine output, the serum sodium, the MAP increase. But for this noradrenaline, you start the treatment with NORAD, 0.5 to 0.5 milligram per hour is the usual starting dose and goes up to 3 mg per hour, 3 gram per hour. And this titration is done and the dose is increased every 6 hours to achieve a MAP increase of 10 mmHg. And you look at the urine output 50 ml over 6 hours, 50 ml per hour for next 6 hours. So the end point there is little different. There is a MAP increase with NORAD. With terlipressin, it is the serum creatinine. And when do you stop? There can be a stopping criteria. The rules can be a person who is 3 to 4 days past is maximum tolerated dose and it's not showing any improvement of serum creatinine, or there is then serious adverse event to a particular drug, which is terlipressin in this case. There can be a serious adverse event in terms of bradycardia or in terms of ischemia, in terms of peripheral ischemia or bowel ischemia, or there is indication which is like transplant. If patient undergoes transplant and then you can stop. So these are the stopping rules for vasoconstrictor therapies.
So if the patient is tolerating terlipressin well, what would be the maximum dose that you can go in 24 hours, sir?
Maximum dose of early.
If the patient is tolerating terlipressin well, but is not responding in terms of HRS, what is the maximum amount of dose of terlipressin per 24 hours that
12
you
milligram. 12 milligram and maximum duration is 14 days.
12 milligrams. Okay, sir. And this patient was having good blood pressure, was maintaining MAP. So would you still use noradrenaline in this patient, or you would be happy with the terlipressin in this patient?
Can you repeat the question?
This patient had good blood pressure always to begin with, 120, 130 systolic, 70, 80 diastolic. The choice of vasoconstrictor here would be noradrenaline or terlipressin. The patient has no other.
The normal MAP is normal. So what do you want? Terlipressin or vasopressin?
So terlipressin here would be the drug of choice because terlipressin has different mechanism of action and different circulations. So vasoconstrictor is splanchnic circulation as well as the renal vasodilatation to increase the blood flow to the kidneys.
Yeah. So this is the imaging. You can see on the CD that the liver is very small. Kidneys are still almost well maintained, the size almost 11 to 12 centimeter. The liver function was, if you saw the LFT to begin with, the bilirubin 0.6, proteins, the albumin level still 3.5, 3.6, INR in the range of 1.5, 1.6. He had a high melt, but that was because the creatinine was driving it. So in this scenario now, do you think this patient needs a liver transplant?
So surely this patient is decompensated, would need liver transplantation. The bigger question is whether he needs kidney transplant along with liver or not. Yes, so the
next question was, would you then consider as a SLKT only liver transplant or a sequential transplant?
So as per the UNOS OPTN policy published in 2017, it is recommended if a patient has an underlying CKD with a creat clearance of less than 35 ml per minute, then these are the patient should undergo simultaneous liver kidney transplant. And if patient who has AKI who's requiring dialysis beyond 4 weeks, then 6 weeks, then I also require. And if there is an AKI, the creat clearance of less than 25 ml per minute, that also requires SLKT. The problem here is that if you calculate the creat clearance for this patient, it could come around 40, 45, which is not exactly into the criteria of SLKT. So there are studies to suggest if there is a HRS physiology, not a structural damage in kidneys, these patients with liver transplant alone respond very well. And they around 40 to 50% of these patients would have normal renal functions. But yes, renal dysfunction prior, like especially the CKD prior to liver transplant, is a risk factor for post-transplant poor outcomes, especially the mortality. Therefore, patient should be kept on a close watch to see how the patient progresses.
So, Dr. Rishi, sir, how would you evaluate, Sir Rishi, sir, how would you evaluate this patient, whether we want to go ahead for SLKT or not? As sir mentioned, we want a GFR of at least 35. So, what would be the next level of investigation?
Yeah, thanks, Mrudul. I think I'm possibly the only nephrologist in the gathering here right now. So, you see, the point here is what is the cause of the kidney disease? So, labeling somebody as CKD is not the end of it, right? We need to know what is the etiology of the CKD, because this patient, when we saw for the first time, the first thought was, is he an IgA with a nephrotic presentation? So the essential thing is the etiology. If the etiology is connected to the liver disease, then I would be more liberal in saying treat the liver first, we'll worry about the kidney later. Whereas if the kidney disease is independent of his liver disease, then he is more likely to require an SLKT.
Okay. So this patient underwent a DTPS scan to prognosticate. It showed a GFR of around 35, 36. We managed him with early present albumin. Urine output used to be 1.5 to 2.5 liters a day. Took discharge, never followed up for more than 1 year. Creatinine was around 1.5. Came back to us in March 2024. This time the creatinine was 3.93 and severe anemia. Again, we managed with early present albumin. Urine output used to go up to 4 liters. So there was still an element of HRS which was responding to our vasoconstrictors. Peak weight in the first admission was 125 kgs. This time it was 95 kgs. So he had lost 30 kgs of fluid. And subsequently, sir, role of kidney biopsy.
Yeah.
Role of kidney biopsy.
No, so definitely this patient requires a kidney biopsy. There's no two things.
So can you interpret this biopsy, sir?
Yeah. Okay, so
the comments show that significant tubular injury and a secondary FSGS. We had discussed about IgA nephropathy because the RBCs were high, but the biopsies never turned up same.
So see, this kidney biopsy is basically showing you this is a chronic interstitial disease which has led to a secondary glomerular pathology presenting with secondary FSGS. So here the primary disease is of an interstitial nature. So some form of an interstitial nephritis that has led to interstitial fibrosis and a secondary FSGS.
Okay, sir. So final diagnosis was alcohol-related DCLD, FSGS-related CKD with the interstitial nephritis causing secondary FSGS and an HRS physiology overlay. He underwent, we did only liver transplant for him. A sister was a donor. Creatinine at discharge, he received basiliximab induction, subsequently was on cyclosporin, which is still taking MMF and steroids. Creatinine at 1.36 on discharge, now 8 months post-transplant. His creatinine is still 1.4, otherwise doing hale and hearty, normal liver graft function. So I would request final expert comments from Professor Norifumi Kawada, sir.
Thank you. I have already summarized this case. This is a complex case of alcoholic cirrhosis. And developed a complex clinical course due to alcoholic cirrhosis caused by prolonged heavy alcohol consumption. And the point of this case as a progression of alcoholic cirrhosis, acute kidney injury, and subsequent decline in renal function, refractory ascites and hepatic encephalopathy, worsening renal function, and development of associated diseases, and decision for liver transplantations. Next slide, please. Yes, sir. So a key takeaway from this case is the profound impact that worsening renal function in cirrhosis can have on prognosis, as well as the crucial role that treatment decisions, particularly regarding liver transplantation, play in patient survival. This case serves as a reminder of the importance of careful evaluating liver transplant eligibility while considering the condition of other organs. Thank you very much.
Any final comments from the panelists? Final comments? Yeah, thank you. Thank you, sir.
Thank you to our moderator and our panelists for this enriching discussion. I now invite the chairpersons for the next session, Dr. P. Shravan Kumar, Dr. Atul Shende, Dr. Chirag Shah, Dr. Preetham Hurkadali, and Dr. Rahul Savalia.
Now we are going ahead for another topic, that is genetic cholestatic disorders in children and adults. Now we invite our speaker, Anshu Srivastava. Please go ahead, madam.
Thank you, chairpersons, and thank you, Akash, for the invitation. I don't have any disclosures. As we all know that genetic cholestatic conditions are basically conditions which are caused by mutations in a long list of genes, which can lead to poor bile formation or bile flow, and that causes cholestasis. In contrast to the myths, the reality is that these conditions are not uncommon, especially in the younger age group, but they do occur across all ages. The clinical presentation can vary with the age, and we have clues to suspect it. Now they are easy to diagnose because of the advances in the genetic testing, and some of them have specific therapy which can really change the outcome of these patients. And so it is worth being aware of them and looking for them, no matter, even if they are uncommon in the older age group. There's a long list of causes. I won't go into the list of causes, but these are all the differentials which we would entertain when we see a baby or an infant who comes to us with neonatal cholestasis. And these conditions account for about 15% of our neonatal cholestasis. I would just be concentrating on 3 important conditions which are seen across the age group from the pediatric to the adult, one of which is progressive familial intrahepatic cholestasis. And now it is of 12 genes which are associated. We started with 3 and now we are 12. And it's important to know our own data because this is a recent publication from India, 278 cases across 16 centers. This is our PFIC registry where we have shown that for us the most common type is the PFIC type 2, whereas a similar publication from Pakistan shows that it is the type 4 which is common. So it's very relevant to know which type of this progressive familial intrahepatic cholestasis is common in our country. Now, what actually is progressive familial intrahepatic cholestasis? These are conditions where there is various mutations which lead to impaired bile formation. So the typical PFIC 1 and 2 basically have impaired bile secretion, raised bile acids in the serum, and a normal gamma GT. In contrast to that, the PFIC3, which was discussed in the case presentation by Dr. Brijesh and Dr. Harshad, is opposite of these in the sense that here the impairment is in the phospholipid secretion into the bile. So the bile is detergent and it causes damage to the epithelium, and so they have raised gamma GT. The important thing which I want you to remember from this slide is that PFIC is an important cause of cholestasis with normal or low gamma GT. This is a very, very uncommon setting as most patients with cholestasis have a high gamma GT, except for this PFIC3. The presentation can vary in infancy with cholestasis. Depending upon the type of PFIC, they can have extrahepatic manifestations from hearing loss to pancreatitis to diarrhea. The type 2 and 6 are at a very high risk of HCC and cholangiocarcinoma starting from infancy. And as I said, all of them except the PFIC3 have a normal or low gamma GT. In the adolescent and young adults, the PFIC3 can present with multiple ways. It can have a brick phenotype, which was discussed. They can present with pruritus in pregnancy, which we call as intrahepatic cholestasis of pregnancy. It can present with recurrent gallstones, intrahepatic gallstones, which is known as low phospholipid associated cholelithiasis. It can present as chronic cholestasis cirrhosis, cholangiocarcinoma, HCC, and obviously increased risk of drug-induced liver injury. So if you have a patient who's fitting into any of these, I would say think about PFIC3 as a manifestation. And what is low phospholipid associated cholelithiasis? It is diagnosed if there is onset of symptoms of biliary colic, acute cholangitis or pancreatitis before 40 years, especially if there is recurrence after cholecystectomy, or if you find that there is stones in the liver, intrahepatic microlithiasis. And how do they look like? You may find this is the typical ultrasound comet tail artifact in the left lobe of the liver. They may have biliary dilatation with intrahepatic stones. And here we have to differentiate it from sclerosing cholangitis and Caroli's disease. Intrahepatic cholestasis of pregnancy is seen in 1 to 2% of the population. Typically, the history is that in the second or the third trimester, the mother has pruritus. There is typically no jaundice, it is only pruritus, which disappears within 1 week of the delivery of the child. But here, if there is severe ICP, which is characterized by bile acids more than 100, then there may be a poor fetal outcome, and so these people need to be treated properly. And in the long term also, these women have a higher risk of developing hepatobiliary disease. BRIC we have already discussed. This is a young adolescent who's coming to you with attacks of jaundice and itching with relatively not very high transaminases, which helps us to differentiate from an acute viral hepatitis cholestatic phase. And it is usually the GGT would be normal if it is BIC related to PFIC1 or 2, which was pointed out with the case discussion. Drug-induced liver injury is again a setting where these mutations, if they are heterozygous, the patient would be absolutely fine till the time he takes a drug which impairs the BSEP or the MDR3 functioning, and then it leads to a presentation with a cholestatic drug-induced liver injury. Various studies have shown that in adults, up to 18 to 34% of these cases who were idiopathic cholestasis or cirrhosis of cryptogenic cause, they had mutations in these genes related to PFIC spectrum disorder. And as has been shown that with MDR3, there is a variant, like if you are heterozygous, if you have small amount of protein which is functioning, then you will have a milder disease presentation, which could be LPAC, ICP, DILI, or transient neonatal cholestasis. But if you have a mutation where there is absolutely no protein functioning, then you're going to present with an early decompensated cholestasis, cholestatic liver disease, which might happen even as young as 1 to 2 years of age. The second condition which I would like to discuss is Alagille syndrome. This is because of a defect in Notch signaling, and here it is a multisystemic disease. So you look at the child's face or an adult's face and you'll be able to make out that this is Alagilles. They have associated cardiac defects, renal defects, and this is also diagnosed by genetic screening, but they have a high risk of malignancy. The third entity is a bile acid synthetic defects, which in children presents as cholestasis, again with low gamma GT. But in adults, it can present with spastic paraparesis, then it can present with xanthomas, cataracts, and ataxia. And this is a disease of bile acid formation. And the presentation varies from diarrhea in an infant to cholestasis, and then to cataract, and then to progressive neurological disease. The diagnosis is made by mass spectrometry analysis or by genetics, but the best part of it, that if it is these patients are diagnosed early and supplemented with cholic acid or chenodeoxycholic acid, it prevents progression of the disease and the patient will have a good outcome. So the approach, how do we approach? When do we do, what are the pointers towards genetic cholestasis in an adolescent. In children, we do it early. But if you take a complete family history and you find that there are affected members, you always do a complete LFT and you find that the GGT is normal or it is 20, 30 and the patient is presenting with cholestasis, please think about it. If there are multi-system manifestations, as I took in allergies and PFIC1, and after exclusion of the common causes, including biliary obstruction by imaging, if you cannot reach a diagnosis, always think of a genetic cause. The diagnosis has now been made much easily available to us and cheaper by the availability of the genetic tests. We can do it in any patient who has presented to you with ascites coagulopathy, in contrast to a liver biopsy. Once you diagnose an MDR3 homozygous in a patient, the family members need to be screened. And now there are recently 2024 and 25, there are good guidelines which have been published on genetic cholestasis, even what to do in adults. If you have a typical picture that of a child who is having features of allergies, then you can go for a specific gene sequencing. But if you have a phenotype of a PFIC, like you have cholestasis with a low gamma GT, then it is good to do an NGS panel, and the yield has varied anywhere from 12 to 60% depending upon the patient population. How do we manage these patients? We give them a good diet, which is MCT enriched, fat-soluble vitamins, skin care for pruritus. For the pruritus, we have a host of medications starting from UDCA, rifampicin, Questran, antihistaminic. We have specific therapy, as I said, for bile acid disorders and for LPAC in the form of Udiliv. The thing which has come up now, which is still not available to us, is the IBAT inhibitors, maralixibat and odivixibat. These are two important drugs which are available in the Western market, which inhibit the absorption of the bile acids in the terminal ileum, and therefore they are kind of doing a medical interruption of the enterohepatic circulation, and they reduce the bile acid significantly, and they have been licensed for the use of PFIC and Alagille syndrome beyond 3 months of age. Genetics helps in prognosticating patients also, because if we find in type 2 or the BSEP deficiency that they have severe mutation, then we know that these children are not going to respond to surgical biliary diversion or to these IBAT inhibitors, and we go straight for a liver transplant. They have a very high risk of HCC. Whereas if you have a person who has got a missense mutation where the gene is functioning to a certain degree, we can first try the antipruritic medication or the surgical biliary diversion or IBAT inhibitors, and if it fails, then only go for transplant. So the nature of the mutation guides us in selecting therapy. Liver transplantation is indicated for ESLD, refractory pruritus or growth failure or HCC. Special considerations if you're doing a transplant in an Alagille patient, because they are prone for vascular aneurysms both in the brain, they are at increased risk of bleed, and we cannot do an LDLT until unless you do the genetic testing in the donor for Alagille syndrome. PFIC patients are at risk for higher post-transplant issues in the form of diarrhea, significant steatosis in type 1, and recurrence of disease in type 2 up to the tune of 16%. So to conclude, I would like to say that genetic cholestatic disorders are increasingly being recognized with the improved diagnostic. They occur across all age groups, starting from neonate to an adult. Variable presentation, cholestasis, BRIC, ICP, LPAC, DILI, HCC, cholangiocarcinoma. Presence of extrahepatic manifestations, family history, low gamma GT cholestasis, please think about it and do a genetic testing. It is a correct diagnosis, can go a long way in improving the outcome of these children or the adults. Thank you very much.
Thank you. Thank you, Dr. Anshu, for your presentation. We have only one talk this session. So
We have rescheduled the talk with Dr. Rinaldi. It will be held tomorrow in Hall B in the morning hours. So thank you so much, ma'am, and thank you for the chairpersons for chairing this session.